Pelage Pharmaceuticals. So like many of my colleagues here, I work extensively in the space of alopecia areata and innovation, really in trial development and design. I am on the scientific advisory board for Pelage. I'm not being compensated for this talk, and this reflects my own personal views and ideas about this medication. We will be discussing everything we will be discussing today is going to be off-label, right? This drug is not approved for clinical use at this time. It is in investigative trials as we speak. So let's start by talking about the present and future treatments for androgenic alopecia. So for a long time, despite this highly prevalent disease that bothers so many people, we really haven't had much innovation. You know, we've had finasteride and dutasteride and spironolactone are medications that are hormonal medications. The only FDA-approved medications are oral finasteride and topical minoxidil. Off-label use of oral minoxidil has occurred. But really over the last 20, 30 years, we haven't had any new mechanisms of actions or any new treatments come onto market. And in that environment with the disease that impacts a lot of people, you're going to get expansion into areas of lower evidence, such as light therapy or a lot of supplements, things along those lines. But what's been exciting over the last 5 years, we've seen added innovation in this space with 2 phase 3 trials. First for a new topical anti-hormonal agent, clascoterone, used for acne, now explored for its use in androgenic alopecia, and then secondly, an extended release minoxidil, which is currently in clinical trials. So for the first time, we have new drugs that are being developed for this condition. The medicine I'm going to be talking about today, pp405, is a mitochondrial transporter target. What's exciting about this is a little bit earlier in phase 2 that has a totally novel and different mechanism of action. Other drugs, such as a prolactin receptor target, are also in phase 2. In phase 1, we have more exploratory medications, the thyroid hormone receptor agonist, and then even stuff looking at stem cells and long-acting PRP that are currently in preclinical stages. So let's talk a little bit through pp405's mechanisms of action, how it came about, and how we think that can help people regrow hair in androgenic alopecia. So in the early 2010s, an observation was made that in patients with androgenic alopecia, even in places where they don't have hair, you still have stem cells there. However, 99% of those stem cells are not active. After some exploration in chemistry, it was identified that one of the things that activates these stem cells is higher levels of LDH. Once they hit these higher levels, those stem cells have the ability to start working and growing hair again. pp405 is a molecule that was designed to enter the cell, inhibit mitochondrial activity, increase the levels of LDH, which then brings stem cells from being inactive into being active. So it's a totally new mechanism and complementary to all the other existing hormonal and other mechanisms of action that we have right now. So when I heard about this mechanism of action, I was super excited. I said, that's great, but if you're activating stem cells, there's a lot of stem cells you don't want activated in the skin, right? Does it cause hyperpigmentation? Does it cause melanoma? Does it cause unusual tumors? Are there growths in the skin? And remarkably, this process is quite specific to only the hair follicle and those stem cells. It does not impact the other stem cells in the skin, and there's a lot of safety data first in animal models, but also now reinforced in human models that supports that. So when we think about patients with androgenic alopecia, what we really focus on primarily is an increase in the total number of hairs. That's not rocket science, right? You want more hair, that's the best thing that you can do for these patients. So we talk about a target area hair count, the non-vellus, right? Vellus are those thin, wispy hairs. We want terminal hairs, thick terminal hairs. And this is the classic outcome measure that's used in trials. But in real life, we know it's not just about the hair count. We know that you can increase the thickness of each hair. That can help quite a bit. Minoxidil does this. You can increase the length of hair. So drugs like minoxidil that increase your length of anagen can lead to increased growth in that regard. But one thing that hasn't really been emphasized before is increasing the number of follicular units with hair. Can you activate follicular units that were previously inactive and cause them to grow additional hair? So what do I mean by a follicular unit? So those of you who have seen hair transplant or are familiar with hair transplant may see these samples on the left of the screen here. A follicular unit is like a family of hair follicles, right? These are the individual hairs that you think. It goes between 1 and 5. They live together kind of in a community, and they share a neurovascular bundle, they share innervation, they come from the same source. So when we're talking about hairs, you can talk about the total number of hairs. If you look at the picture on the right, you can see each of the hairs is outlined in yellow, right? You can see that each of these is an individual hair. There's 12 hairs overall. But if I take away the numbers and you look at those little targets at the base, each of those targets is a follicular unit. So what we have is we have 12 hairs, but we only have 9 follicular units. So based on the mechanism of action of pp405, the question that we had is, can we actually activate follicular units that didn't have hairs in them before, not just increasing the number of hairs existing in currently active follicular units? So before I go further, I really want to talk about where this data that I'm about to show you comes from. So this was a phase 2A study design. This was not an efficacy trial. The goal of this study was not to see how well pp405 works. It was really to see how safe is it, how is it tolerated. And the good news is that from a safety and tolerability standpoint, it passed with flying colors. There's no concerns there. So this treatment, what the data I'm going to show you, is only from 28 days of treatment. This is not the way that this drug would be used. It's only used for a month. So think about everything else they use for hair and how short of a time period 1 month is. And the outcomes I'm going to show you are at day 84, okay? So they only got 4 weeks of treatment. I'm going to show you the data from 12 weeks. People were randomized. There was 78 men and women overall, 2 to 1 from active treatment to placebo. So let me walk you through this slide, and this is the moment of truth where I'll see if my video animation works. But what we have here is we have a baseline photo of one of our patients. That black dot in the center is not hair, that's a micro tattoo. That's how you can make sure that you're taking a picture of the same place every time. This hair is shaved, so we're not allowing it to grow. We're shaving it so we can really look at the hairs individually and count them. So I'm gonna play this video in a moment. You're gonna see 3 things. You're gonna see first, yellow circles, or gold circles. When you look at those circles, you're going to see areas where there's new hair growth in follicular units that were already active. So these had 1 or 2 hairs, they got additional 1. The red circles are going to be what I was just talking about. Areas where there were no hair follicle, the follicular unit was not activated, but a new hair grew in a new follicular unit. And finally, on the right, you're going to see in the teal, thick hairs that are replacing vellus hairs. You had these baby hairs that were there, and over time they were replaced by the terminal hair that we're very much looking for. I'm going to play this video for you twice, so don't worry if it's hard to see the first time. All right, so now you see the gold circles, and what you're seeing is new hair growth as it switches to day 84 there. And the red circles, these are areas where there was no hair before, and by day 84, you're going to see new hairs coming out. These are newly activated follicular units. And finally, in these teal areas, they're thin, wispy hairs. They may not project well, but they become terminal over time. I'm going to play this one more time so you guys can see it again. For this first time, it's hard to see. So gold circles are going to come. These are areas where there was hair. Now we have more hairs in those units. Next, in the red circles, there's no hairs there. There are no follicle units there. Now they're activated. New hairs are coming. And finally, you're going to see in the teal areas thin vellus hairs and how they're becoming more terminally differentiated over time. You can see a similar pattern in a second patient. See if I can, This patient has more red hair. Again, this red dot in the center is a micro tattoo. That's just for us to localize it. And again, this area has been shaved. And again, we're going to look at the same schematic. I'm going to walk you through it. So we start off and we see gold circles. These are areas where there are hairs. And now at day 84, there's more hairs coming out of those follicles, follicular units rather. And the red areas are inactivated follicular units. They're now becoming active. You can see new hairs coming out. And finally, in these teal areas, thin hairs that are now becoming more terminal over time. So this animation, this shows showing you these different time points, really shows you the nature of the hair regrowth that's coming. Now, in patients that are not treated, right, in normal hair, placebo patients that just receive vehicle, it's not as static as you might think, right? We don't look at our hair and be like, oh, every day it's changing, but we know that hairs are falling out, hairs are growing, things are changing over time. Let me show you the differences between these treated patients and one of our placebo patients. So in this patient, again, with the large micro tattoo in the center, what you're going to see is that all 3 of these things occur. They do get new hair coming out of active follicular units. They do get new hair that's coming out of inactive follicular units, and they do have some vellus hairs that change. But look at the distribution of these circles and how they go. So starting here, you do have some activity. This is a person that grew a lot of hair over the trial. These are areas where there were hair follicles that are active and they grew more hairs in it. We only have 1 follicular unit that was activated and grew a new hair in this image. And then from a vellus standpoint, there's only 1 or 2 areas where the vellus hair became more terminal. So it just shows you again, 1 patient compared to a couple of active patients. We can give you a sense of how this drug may be working. So that was looking at 3 individual cases. Let me walk you through a little bit more of the aggregated data. This is a collection of data from the men in the study. It's about 41 of them here. On the y-axis, we have the change in the non-vellus total hair count. So this is the terminal hair that we want to grow, the primary outcome of a trial. In the bottom, on the x-axis, we have the change in the number of activated follicular units. And when you plot these two against each other, what you can see is not only are most people growing their hair, right? They're mostly in that top above 0 for change in vellus hair count. But when they are growing it, they're growing it from the newly activated follicular units, that this really is the mechanism by which new hair regrowth is occurring. I'm not showing you the data, but we have a call out in the bottom right. When we did the same graph for patients who have been on placebo, yeah, they're having some newly activated follicular units, et cetera, but that line is totally flat. There's no correlation. That's not where any change in their hair count is coming from. So it shows you the difference between the treated patients, again, treated only for a month, and then testing 2 months after that. So really it was a long duration after their initial exposure, a long time off the medication. Another thing to note is that when we look at the placebo patients, so this is only the placebo patients, we're charting, again, on the x-axis, you have the activated follicular units. On the y-axis here, you have total area hair count, but not the terminal one. You're looking at the vellus ones, those little baby hairs. Whenever they do have growth of these newly activated follicular units, they're not able to get to terminal hair. They're all in the vellus growth. So those terminal hairs that really matter for how we look are not being changed, but those new baby vellus hairs are what's driving it. So putting this all together, what's exciting about this drug is that overall, what we see from these images and what we see from the data is an early sign that the purported mechanism of action of this drug, that it activates stem cells, that has a potential for regeneration from that standpoint, that is likely the way that this is working, and which gives us a different mechanism of action and a different mode of growing hair compared to existing drugs on the market, a very complementary way. So walking through the cartoon here on the right, so look, you have here 2 empty hair follicular units, A and B, and you have 2 follicular units that have 1 and 2 hairs in them. With pp405 on the left, you're getting additional hairs in existing follicles. In addition to that, you're getting terminal hairs in previously non-active follicular units. In contrast with the vehicle, you do occasionally get a new hair. Those new hairs that are terminal are coming in the areas where you already have an activated follicular unit. And if you do activate a previously dormant follicular unit, the vast majority of those are going to be those thin vellus hairs that don't really add to the cosmetics and improvement for our patients. So overall, we're talking about the future, and the excitement around this drug is that pp405 drives new terminal hair growth by activating previously dormant follicular units. And this is really, again, consistent with what we saw, what the purported mechanism was, what the design of the medication was meant to do, what we see in animals, and now we're seeing it in humans for the first time. We believe that the follicular unit count is an important metric that can be added to the total area hair count to really understand how drugs are working and how they can impact patient. Activation of these dormant follicular units in androgenic alopecia may be possible if these results bear out in additional trials. And the growth of specifically non-vellus hairs in these may be an additional area, of benchmark that we can look at to establish the efficacy of these medications. We're really excited that more trials are coming, hopefully beginning later this year, and we really need to continue to establish the safety and efficacy of this medication. Thank you very much for your time.
Thank you. All right, so Jeremy's going to take over my job, so you can sit on the podium. Yeah, there's fine. All right, so we're going to move on to our next speaker, Dr. Jeremy Green, who comes to us from South Florida. Jeremy gives this talk an update of toxins and fillers each year. I've given him an extra piece of responsibility, which is I have a talk in 3 minutes on the other side of the convention center, so Jeremy's going to chair the session for the next 10, 15 minutes as well, and I'll be back. So advances in toxins and fillers next 1 to 5 years. Thanks for coming back, Jeremy.
Please don't all leave with Matt. I worked really hard on this talk. So my name is Jeremy Green. I'm a dermatologist in Miami, as Matt mentioned, and I'm honored to be here with you all to discuss a pipeline of toxins and fillers. I'll share my disclosures because we do clinical trials as part of my practice, but the disclaimer is I'm sharing publicly available information, so there's no suggestion of whether or not something will be approved, but hopefully to make this talk interesting to you, think about how you might use these products in your practice if we are to get them in the US. These are my disclosures. Let's start with neuromodulators. So where are we going in the next 1 to 5 years? Well, one indication that's under investigation here in the US is masseter muscle prominence. So this is an aesthetic indication, importantly. This is not talking about TMJ, bruxism, et cetera, a purely aesthetic indication. And the indication dose investigated is 48 units, meaning 24 units per masseter in 3 injection points. I'm sharing the schema with you here, 8 units per injection point. This is one patient representative, 3 months post-injection, beautiful slimming of the lower face. Important, the question arose, with these treatments, there's some reports of change in mandibular bone density. So there is a paper where patients were followed with dose escalation at higher doses than 48 units as well, with serial CT exams for up to a year, and there was no change in mandibular bone density, which is important. So stay tuned for this potential indication. What about new products? What about a ready-to-use liquid botulinum toxin? So this could enhance safety. I've added these vials here because there's published reports, and I've heard from friends and colleagues of neuromodulators, botulinum toxin, being inadvertently reconstituted with all of the following vials, which can be scary. So the advantage of a pre-filled syringe could be, or rather vial, could be safety in this regard, convenience, consistency in dose, and also lessening the burden of your staff, so lessening potential for human error. What are potential other things that we'd have to consider with a pre-filled vial? One is it's a fixed dilution. I like to use different dilutions in different parts of the face and body with my neuromodulators, so it will come in a fixed dilution. The second is pre-filled vials will be manufactured with non-preserved saline. We use bacteriostatic preserved saline in practice with benzyl alcohol during COVID when there was a supply chain shortage of just about everything. Some of you are nodding your heads like you had the shortage as well and you had to use the non-preserved saline, and it's definitely a different experience for patients. So that's also something that will be of interest. There is a product called relabotulinum toxin A that is a ready-to-use liquid botulinum toxin serotype A1. It's complex protein free. It's just the core 150 kilodalton neurotoxin protein with no human or animal-derived excipients. It already has EU approval for glabella lines and lateral canthal lines since 2024, also approved in Australia and parts of Asia. There's a very large phase 3 clinical trial program here in the US and Canada, which enrolled over 1,900 subjects. So clinical performance is very important to us, and the primary endpoint was a 1-month composite 2-grade responder rate, meaning both investigators and subjects had to rate themselves 2 points better on a 4-point GFL scale, which we'll discuss. And so 83% achieved that composite endpoint and 96.3% for subjects self-assessed at 1 month. But this is the curve that I think is most interesting. This is the duration curve, and this is telling us percentage of subjects that achieved none or mild. So patients were moderate or severe to be enrolled, they achieved none or mild. You saw the 1-month primary endpoint, but look at month 6. Investigators, about 24%, assessed that patients were still none or mild at 6 months. And subjects themselves rated themselves even better. 44% thought they were still none or mild. So what does all that chart look like clinically? This is from that same publication where at baseline, all of these patients were rated 3, severe. The top row at 1 month, she was a 0, none, and at 6 months, she was a mild, 1. So she was still responder at 6 months. So impressive clinical performance. Second row, 3 at baseline, 1 at month 3, 1 at month 6. Last row, 3 at baseline, at day 7, 0, at day 6, 1 month. So that's still pretty impressive response at 6 months. So think about how you might consider, or whether you might consider integrating this into your practice. What about a rapid onset botulinum toxin? Usually we tell patients it's going to be 3 to 5 days or more. Please don't bother us for a touch-up for at least a week or preferably never, because we usually make those touch-ups complimentary, right? We say lose our number. No, I'm just kidding. But what if you had a rapid onset botulinum toxin? So there is one that is under investigation. The trials have been completed. It's botulinum toxin E. So there are 7 serotypes of botulinum toxin, A through G, and this is serotype E. So similar to type A, there's 2 protein chains, the 100 kilodalton heavy and 50 kilodalton light chain linked by the disulfide bond. Also inhibits neuromuscular transmission via the presynaptic SNAP25, but a different cleavage site I'll show you. So there's fast onset within a day, and a shorter duration within 3 to 4 weeks. So here's what this looks like. At the BONT-A cleavage site, the onset is more slow, right? 3 to 5 or more days. At BONT-E, rapid onset, but rapidly repaired by the body within 2 to 4 weeks. So that is why you see return of that GFL movement. Here is some data, also robust clinical program. The results you're seeing are a composite, 2 grade or more patients moving on that 4-point scale. And look at the primary endpoint at day 7 to see where participants and investigators rated themselves as far as, and again, you'll see something between 60 and 80%. But remember, this is subject and investigator. It's harder to achieve that composite 2-point rating, 2-point movement on the scale. Of course, whenever we get a new product, our primary concern is safety. And our most dreaded clinical complication, lidptosis, 4 out of 482 patients experience lidptosis, which is a lower percentage than most botulinum toxin labels, if you were to go through them and see. Also, safety, concern, immunogenicity. We have a new serotype, and of the pooled data, 1 out of 2,104 patients developed anti-Trenibot E binding antibodies after 3 treatment cycles. So it appears that it's a pretty safe profile, both clinically and from an immunogenicity standpoint. Now, other experience in the data treating different age groups, different genders. There's one report that was presented at the ASDS which showed sequential treatment. Trenibot E, 30 days later on a botulinum toxin A. Again, showed no increased immunogenicity, et cetera. So really, how might we integrate this into our practice if we get it in our armamentarium? So this patient at baseline was rated moderate, so a 2. By hour 8, 0. So complete clinical efficacy by hour 8. Same thing at day 1, day 7, day 14, but by day 21, this is the curiosity of clinical trials we run, we use scales, right? So this patient was rated at returning to baseline, but you still see clinical effect, right, in the glabellar region. He's rated as a moderate, but still some clinical effect at week 3. So how might you use this? Those patients that come to you on a Friday afternoon and say, I have a huge event tonight, I want to look beautiful, you could use this. When I was training, do you remember the first time you injected a patient, how scary it was to inject toxin in someone's face? And you did it, and they were like, how'd I do? And you're like, great. And you had no idea. Did I drop their lid? Did I kill them? Did I do anything? Here you're going to get not real time, but very short-term feedback. So this could be a great educational tool as well. Also of interest, and there's some investigations ongoing, what about co-administering A and E? That is also something that we might consider. What about, and so these are different serotypes, different formulations, but what about the future? What if instead of taking botulinum toxin, native botulinum toxin from Clostridium botulinum toxin and extracting it, what if botulinum toxin could be engineered for the most favorable characteristics to deliver sort of a bespoke botulinum toxin? And those products are starting to exist. There are recombinant neuromodulators, which involve fully or partially modifying genetic sequences of native BONT expressed in a non-clostridial host, such as E. coli. There is one product, IPN 10200, which is the first recombinant molecule. It's engineered to increase receptor affinity and internalization with the active sequence of serotype A and the binding sequence of serotype B. In phase 2 clinical trials, the comparators were both abobotulinum toxin A and placebo. Phase 3 clinical trials started here in the US this month. There is another company out of China, YY003, which is another recombinant botulinum toxin in structure consistent to BONT-A. There's not a lot of available information that I could find, but it's a liquid pre-filled syringe, and phase 3 trials are ongoing in China and Australia. So this is interesting. What if, like, with lasers, we can pick a laser for a specific indication? What if toxins can be designed for specific regions of the face or specific indications? So that's, I think, very fascinating, something that we have to look forward to in the future. Let's switch gears to the injectable fillers pipeline. And hot off the press, just 5 days ago, there's a new product approved for the temple indication. And the reason why I share this with you, and I encourage you to look it up, is the injection schema used in the clinical trial, I believe, is superior to the one that we were all raised with, the one up, one over, as far as safety and efficacy. So I've adopted, I use this exclusively, this injection paradigm in my clinic. So I encourage you, if you're interested to learn more about temple injections, to seek out that label and that education. HA is also under investigation for tech neck or horizontal necklines, which I think we all have. There are next generation HAs under development with different cross-linkers as well. But kind of the hottest thing, I think, right now in the US and probably the world is injectable biostimulators. In the upper right-hand column, you see let's see. In the upper right hand of your screen, you see calcium hydroxylapatite, microspheres, and PLLA microspheres, polyallactic acid. And here in tissue, in human tissue, you see that there's an activation of our immune system, which leads to a cascade of neocollagenesis, neoelastinogenesis, extracellular matrix formation, like hyaluronic acid. So these are activating products. These products are absolutely on fire and very popular right now. They really resonate with that biohacking, regenerative medicine, that crowd that says, I don't want fillers, but I want PLLA or CAHA. And you're kind of like, okay, as long as you're letting me inject your face, you could call it whatever you want, because it does volumize. But so there's a little bit of a disconnect in their mind, but they're really loving these products. And so new indications with these products under investigation: cellulite, thighs, buttocks, décolleté with both CAHA and PLLA. So this is something to pay attention to new indications. What about new biostimulator products, which would be new to the US, potential products? There is a premixed hyaluronic acid and calcium hydroxylapatite product that got the CE mark for Europe in 2022, also approved in other countries. And it is a combination of HA, 20 milligrams per ml, and calcium hydroxylapatite, 25 to 45 micron microspheres. Here's what the product looks like. And this is an injection paradigm from a recent publication in JCD 2 months ago from Andre Braz in Brazil and colleagues, where they're using a 22-gauge cannula and injecting this all over the face for structural support. The idea behind it is you get structural support and a persistent volume effect while you're still getting biostimulatory benefits of calcium hydroxylapatite, right? The CAHA product we have, I love, it's beautiful. It has a carboxymethylcellulose gel carrier, which is absorbed, and then the CAHA is the main driver of what we see in the skin. So this, the HA, it's purportedly more durable aesthetic outcome in that regard. This is one of the patients from the publication in Brazil treated, beautiful result. The volume wasn't specified. Another potential biostimulatory product that is in phase 3 trials in the US right now is polycaprolactone, or PCL. This product, also 25 to 45 micron microspheres, but this is PCL, polycaprolactone. And this product has a GRAS designation by FDA, generally recognized as safe, because it's already in our sutures. It's monocryl. It's already in some forms of birth control that are implantable in our patients. This is with a 70% aqueous carboxymethylcellulose gel carrier. So the product is on the right. On the left, you see it was a small cohort of just 2 patients, but they had an intradermal injections in the temple and had brow lift surgery 13 months after the injections. And so here you see the PCL particles are persisting in the skin, and you see the robust collagen response around the PCL. So what does this look like clinically? This is a study from China of 160 patients, 80 of which who received PCL injections in the nasolabial fold. 80 received non-animal stabilized hyaluronic acid, or NASHA, the product that we have in the US, HA, NLF. And the way this chart is oriented, the delta, the negative, is changed from baseline, so it's improvement in WSRS score of the nasolabial folds from baseline. So both did a great job initially and at 1 month, and you start to see the products diverge, where the score of the NASHA in blue started to return to baseline, and the PCL had persistent effect. The last biostimulatory product that I'll discuss with you is a novel PLLA from a Swedish company. It achieved a CE mark, so Europe, in 2024. And in this case, it is 45 micron PLLA microsphere. So how does this differ from what we have? You saw the particles of PLLA I showed you earlier, and here are other PLLA particles with electron microscopy. These are spheres, so these are smooth spherical particles of PLA. So the reason, or purported reason for doing this is less clumping in injections, perhaps less induration or nodule formation, which can be an issue with PLLA, with all PLLA. This is a small study from Spain of 36 women. This product is reconstituted with sterile saline as opposed to sterile water, which we use with our PLLA currently approved. These patients were treated with a 25-gauge cannula, similar injection paradigm to what we use now with our existing PLLA, 3 treatments spaced 4 weeks apart, 1.5 ml of product per nasolabial fold, and at that WSRS score at 6 months, 72% had at least a 1-grade improvement. And this is one of their patients before and after. They also performed ultrasonography and elastogram, which showed increased tissue density, neocollagenesis, and neoelastinogenesis. So again, all of these products are foreign, they're biocompatible, but they're inducing an immune response which stimulates good things, collagen, elastin, et cetera. But what would really be the future of injectable fillers? And so what if we could inject something that did good things without having an immune response as an intermediate step? And I think that's the future, is true regenerative aesthetic medicine. And again, not to besmirch those products, because I use them every day in my practice and I love them, but true regenerative aesthetic medicine, there are companies that have filed IDEs in the US on clinicaltrial.gov, investigational device exemptions, where they're looking at biomaterial scaffolds, plant collagen, animal-derived dermis, so all sorts of ways where you can inject a scaffold or a matrix whereby our own tissue will reconstitute that matrix. So that, to me, is fascinating, and that's truly the future of fillers. In conclusion, again, I'd like to stress these are all potential products, but in the next 1 to 5 years, we could see a ready-to-use botulinum toxin in a pre-filled vial, a fast-onset, short-duration botulinum toxin, maybe further downstream recombinant botulinum toxins that are engineered specifically, which may reduce toxicity and enhance safety and clinical performance. Next-gen HAs are under development. There's interesting indications which resonate with our patients now. Maybe a CAHA HA premix product, PCL, a microsphere, PLLA, and again, downstream, what's really exciting, we may have true regenerative fillers. Thank you so much for your kind attention. And our next speaker needs no introduction, but Dr. Chris Zachary, Chair Emeritus at UC Irvine, eloquent speaker and very nice human.
Jeremy, thank you very much. Thank you, Matthew, even though you're not here. There we are. It comes up. So, in talking with some of my Mohs, so I'm a Mohs surgeon, by the way, but I haven't done Mohs surgery for a couple of years, etc. But otherwise, 38 years of Mohs surgery. But I always wanted to be able to have a patient with a basal cell cancer and then have a device that I pressed a button and something happened. And I just want to talk about some of the work that I've been doing over the last 6 months, 6 years rather, that I think is of some interest. These are my disclosures. So this is a nomogram, and on the x-axis you can see temperature in degrees centigrade, and on the y-axis a logarithmic scale of time, these are isotherms. If you look at the red axis right in the middle with the star on it, that was our first study that we did, which was 55 degrees for 60 seconds. Now this is quite different from the treatment that Matt has talked about, which I have called the standard or the basic system, and you'll see some references in this talk with regard to the controlled hypothermia study or CHAMP study and the basic study. So as you move from the there we are. This is the isotherm. At any point along here, you get the same Arrhenius damage, which is essentially programmed cell death. All right, and as you'll see in a few minutes, at 55 degrees, let me just come back here. At 55 degrees, it takes about 60 seconds I'm using this pointer over here, we go. 60 seconds, all right, to get an Arrhenius of 1. And that's enough to kill the cells that we're looking at. I can't use this pointer very well. If on the other hand, you come down at 50 degrees, for instance, then it takes about 100 minutes or so to get the same effect. And so that's an important factor. Now, yeah, I know it's not very bright. We're living in the old ages, I think, when we talk about electrodesiccation and curettage, because this always gives rise to some scarring, etc. And I think we're in the 21st century, and I think we can probably do better than that. So let's move along. This is one of our patients who was actually probably one of the first patients who was treated with controlled hypothermia and monitored protocol. And you can see on the left a basal cell cancer, pretty obvious, and at the right, day 36. Yes, there's a bit of post-inflammatory hypopigmentation. You can see a biopsy site there. But the point is that there's been no cutting and no stitching. And I'm not saying this is for everybody, but this is for a lot of patients who are in their 70s and 80s who've got lots of basal cell cancers and who are fed up with Mohs or whatever, and they just want a simple system. Now, this is all based on a lot of very good science, previous science, and I won't spend a lot of time on this, but it's the controlled hypothermia apoptotic reaction that puts all these cells into programmed cell death was well described and is related to capsase 7 and capsase 3 and mitochondrial change, etc. At the same time, the CHAMP, which stands for Controlled Hypothermia Monitored Mapping Protocol, it's important to try and actually measure these beforehand. You can see the obvious nests of basal cell cancer there, just below the epidermis, and which are compared with histologically down below. And now that we've got AI associated with this, within a few seconds you can actually see where the tumor is, both nodular and superficial, and you don't have to look at each of 360 sections of OCT to be able to see where the tumor is. So this would be one of our patients, for instance, on the left shoulder, obvious basal cell cancer. We're going to treat this to 55 degrees for 60 seconds, and we'll video this with the forward-looking infrared camera. And you can see on the right the OCT, which images the tumor. And here's the patient. Here's the FLIR image on the right-hand side. And after treatment, you can see a lilac gray. Now, the big difference between this treatment and the traditional treatment that Matt was talking about, he gets some contraction, some whitening. When you're up on the right-hand side of the nomogram, when you give too much energy, too much heat accumulation, then you get contraction and necrosis of tissue. This is not necrosis of tissue. This is programmed cell death that you're seeing here. This is a lilac gray. And here's the end of 3 months. Yeah, a little bit red. And here's the OCT, which shows it's gone completely. We always biopsy these. We excise them at 3 months. And on the left hand, you can see that 90% of these, nearly 90%, were relieved of tumor. And on the right-hand side, this is one. Incidentally, the superficial ones, as Matt said, are more difficult to remove than the nodular ones, which are simpler to remove. And in our protocol, we had up to 3 treatments. In the next study, there's just 1 treatment, but you can see it reaches nearly 90%. What is relevant here, if you can look at the cumulative dose which is predicted, and this cumulative dose predicts clearance. I'm sorry, I'm not very good with this. There it is. Okay, I don't know if you can see the pointer here, but this is the basic technique on the right-hand side, where the subjects have actually received hundreds or thousands of times more energy than is needed. On the left-hand side, you can see that the CHAMP technique requires much less energy. And what's relevant is that the omega of 1, the Arenas omega of 1, which is the threshold for irreversible thermal injury. And if you look at this on the chart on the right-hand side under CHAMP, some of our lesions were not clear, and it's very obvious that the ones that were not clear actually had some cold areas. You see, you can scan the skin. You can scan the skin with uniform 1064, but the heat, the tissue will not heat up uniformly. And here you can see with a dynamic OCT, at the top is the before the treatment. Below, in the middle section, is immediately after treatment. In fact, there's not decreased blood flow. There's increased blood flow with the CHAMP technique. And this is demonstrated figuratively here. afterwards. On the left-hand side, you can see a significant increase in blood flow and compared to the basic technique. So in the future, what can we do? Well, we've devised with the Cyton, we've actually devised a technique whereby every single pixel of the device knows the temperature. So we know temperature and time, and that will give you the total accumulative dosage. And you can see as these reach up to an Arrhenius omega of 1, you can see that actually the treatment areas, they fall off, etc. So we can be much more specific. So in the future, this is the appearance that we're looking for. We get a peau d'orange type appearance, lasts for about 7 to 10 days, no ulceration, no obvious necrosis. Day 15, you see a little bit of increased vascularity. And this is day 200. This is actually on my arm, just so you know. And you can see normal skin tension lines. And I also have vitiligo, so you can see exactly where this has been. So in summary, beta cell cancer can be effectively treated by controlled hypothermia. Heat treatment of skin cancer is complicated. The conventional long pulse 1064 treatment of beta cell is not well standardized, but we believe that it can be in the future. And the development of this robotic Arrhenius cumulative dosage essentially system, which we've developed, allows precise heating. I'd just like to thank everyone, both David Ozog and his team at Henry Ford, Kristen Kelly, and all the groups, the engineers who make this possible. Thank you very much.
Chris, question and answers.
Oh, yeah.
Do you want to run it?
No.
All right, we have a little bit of time for questions. If anyone has any questions for the last 3 speakers, please go to the microphone. Yes.
Okay, so my question is to you. Do you have experience with penile Botox?
Penile Botox, no personal experience. Patient or injector?
And what's your opinion on that? Because I have experience with that and started using it.
It's interesting. I mean, I'm not sure that that's ever an indication that companies would go for here, but how are you using it? What is your experience?
The point is to inject it into corpus cavernosum, the body, to actually relax the smooth muscles. And there is a study actually now in USA which significantly improves erection.
Oh, interesting.
In patients, yes, even with severe erection problems.
Well, please publish that.
Okay.
It'd be interesting for all of us to learn.
You can search it. It's available online, and it's here in US.
How do we find it?
Just Google it. Penile Botox.
I can't Google it. I'll get in trouble, I think. My browser. Are there any other questions? Thank you so much.
Okay, thank you.
Are there any other questions for Dr. Zachary or Dr. Arash?
Chris, wonderful presentation. All of them, but specifically because it's one of the first robotic devices, and you do. But still, I have a question. So you calculate the Arrhenius integral, which gives you the damage threshold, but that assumes also you have a different damage threshold for the cancer than, because otherwise you would create a complete ulceration. Or any comments on that? How you get the selectivity? I mean, you have the local selectivity, but if you above damage threshold, you should damage all cells, basically, or do I miss here something?
No, I would agree with you. I think that first of all, 90% of these tumors went away, first of all, with a rather primitive device that we used. Secondly, all the cells are involved in this Arrhenius-derived programmed cell death, which you can see on normal skin, obviously, and we've demonstrated it on tumors. Now, you might say that tumors develop heat shock proteins very often, as these might, and in fact, we used an Arrhenius of a cumulative dosage of 1.4 on quite a lot of these patients more recently. But that's a very good question. It's not that selective in as much as it puts all the cells in the treatment area in this programmed cell death path, but there's recreation of the cells of a more normal manner.
Yeah. And then also you may want to look into some substances that selectively enhances the susceptibility, the sensitivity to thermal treatment, like and meds in the past published also lidocaine also increases, and that is somehow in the old hypothermia literature. There are some substances that selectively increases the vulnerability to heating, basically. It's something you may.
That's a very good point. Like, we use lidocaine without epinephrine for these patients because at 55 degrees, obviously, that's not tolerable. But that could well be one of the reasons why they're sensitive. Yeah. Thank you.
Thank you.
Dr. Green, I'm Ron Selesky from Omaha in Miami. I had a question, if you had to predict in 5 years or maybe 2 years, how will you be dosing the botulinum toxin E with the A?
I think, what's most compelling to me potentially is co-administration. Again, what will be interesting is what that does to immunogenicity, but also the curves that you saw. Will that potentiate the effect of A? Will they perhaps interfere with each other if they're both trying to get to SNAP-25 at the same time? So the answer is we don't know, but if there's potentiation of effect or same duration with rapid onset, I could see myself co-administering these products. Thank you, Dr. Selesky.
Dr. Green.
Thank you. Thank you all so much. I think we'll move, without Matt, to the next section of, oh, sorry, there's one more question. I'm so sorry.
I'd like to ask about the compound 405 for stimulating the stem cells, the mechanism, how to stimulate the stem cells. The second, when the stem cells transformed into follicular hair, it will persist without entering into the AGA again, or will keep the acquired or the genetic stability to develop AGA?
Great question. So when I was in both undergrad and medical school, I had to memorize the Krebs cycle, which I memorized for about 3 hours for the exam, and then I never thought I'd have to use it again. And how pp405 works actually works through the mitochondrial process of how the metabolism of the cell is developed. We can give you more specifics about it, but it basically builds up pyruvate, which leads to increase in LDH, which then seems to trigger these cells. Now, the question you asked about long-term result, right? When it is activated, does it remain activated? Is a wonderful question. We have from animal model that we know that once it's activated and they continue getting the medication, that they will continue to grow the hair. We don't have that data yet for humans or for what happens if you stop, if there's a withdrawal. So we don't have that, but it's something that we're going to be evaluating in upcoming studies.
All right. Thank you, panel. I missed all of it. I'm sure it was fantastic. I expected a little applause. All right, well, let's a little applause for our panel. It is my pleasure to invite up to the podium one of the true giants of our field, Dr. Roy Geronimus. Roy is as good as anyone to talk about future of laser and light source treatments, what we might be seeing in the future. He's seen the future for a couple decades now and done a great job of giving us the right view into the future. Roy, thanks for coming.
Thanks for having me this morning. Good morning, everybody. So let's talk a little bit about the future and a little bit about the present, and I'll do a little speculation here as well. Let's see. Advancing. Here we go.
You hit the clicker.
There we go, relevant disclosure. So I posed the question to AI about the future of devices, and this is what it came up with. Dermatologists will likely lean into faster fractional lasers, smarter energy-based devices, and AI-guided platforms that tightly personalize treatments over the next 5 years. I think that's true. Definitely we need AI adapted into the technology space. One of the problems that we face with technology is that the technology field is basically underfunded at this point in time. We need some 800-pound gorillas in the technology space like we have in the medical side of dermatology to really move this forward. So I basically, let's go on to this, took out my crystal ball to help determine what might be happening in the near future. And I think we will be seeing reproducible tightening and lifting devices and volumization over the near future. We're going to see home devices that will expand even further into the marketplace. You know, all of us in our practices are seeing these patients coming in asking about red light devices, you know, some of which work and some of which don't. We really don't really know. But I think we'll be seeing more devices. And in years past, there was an effort to have home-based fractional devices that really never got off the ground. Some of them were actually pretty good, but the marketing wasn't great. And I don't think that the physicians and the public really understood the potential value. But now that we're interested in the concept of laser-assisted drug delivery, I think we'll be seeing more of this as well. We'll be seeing more combination devices and techniques where we do things together. I'll be talking a little bit about that today. And I think we'll be seeing more devices being used for medical conditions. So the technology that we have will be more mainstream, where general dermatologists will be using these devices for more than just medical purposes. So there's some unanswered questions that we have today. Will the devices that we have be clinically significant for tightening and lifting on the body? There are a lot of claims, and I think there will be some need for this. You're going to see more and more patients coming in with lax skin, particularly with volume loss from GLP-1 drugs. Will there be devices for meaningful hair growth? Maybe after today's presentation we don't need devices, but certainly it may facilitate the use of the topicals that you just heard about. Will acne lasers become a routine part of dermatology practices? I think they will be. I think that these devices are underutilized. You'll be seeing improvement in the technology for acne treatment. They will become faster, they'll become less painful, the kind of thing where you can walk in and do a treatment in 10, 15, 20 minutes rather than what we're seeing today. And I think this will be something that will enhance the utilization of these devices, which really do work when used properly. Which medical conditions will lasers and other technologies become an important treatment? And the other bigger question I think we all have to address is, will the proliferation of unskilled and unsupervised providers of lasers and related technologies lead to an unacceptable rate of complications, leading to stricter scope of practice laws? And that's another subject for another time, but something we really should all be considering. I don't know what you're seeing in your practices, but the number of complications I'm seeing in my own practice coming from the outside of unskilled providers and physicians, non-physicians, is something that is alarming and truly a big problem. So I'd like to move on to the discussion of focal point technology. This is a laser treatment that is a bit different than the fractional lasers we're used to. It delivers higher energy, up to 150 millijoules. It delivers laser light that focuses deep into the dermis or the mid-dermis, or superficially. You can adjust the energy. This is a non-ablative treatment, topical anesthesia alone, developed by Dieter Manstein, who's here today, and Rox Anderson. So this is what we see histologically. You see this V-shaped pattern where the energy is delivered and focuses the energy deep into the dermis, sparing the epidermis. I did the clinical trial, some of the clinical trials with this device, and one of the first observations I made was I was surprised that it was less painful than the alternative non-ablative fractional device at 70 millijoules. So here we are doubling the energy or more, and we're able to see a diminished amount of discomfort, which is quite unique and quite interesting, but it's very apparent early on. So you can adjust the energy depth with this device. You can go superficial, you can go deep. In my practice, I do both. So somebody coming in who wants to get some volumization, wants to get some improvement of skin, some skin tightening, some skin lifting, treatment of scars, I will combine a superficial treatment and a deeper treatment at the same setting to improve the outcome. And you can see here histologically you can get different depths, and this does differ compared to what we've seen in the past with the conventional non-ablative fractional device at 1550. This technology is also a platform and ultimately can be used with other wavelengths, and that's in the future. I think we'll be seeing 1064 with this for the treatment of pigmentation, and perhaps other wavelengths for the treatment of other conditions, whether it be vascular or other concerns that we have. So just to give you a view of what one can do with this device, you can treat skin of color. Here we're treating a patient with very high energies for the treatment of acne scarring, pre and post treatment. For rejuvenation with some volumization, so let's focus on her eyelids here. Here just treating a little bit below the orbital rim and above on the forehead. You can see some nice tightening of the eyelid skin pre and post treatment. And you can see the lifting that occurs over several months. So as there's some rejuvenation and neocollagenesis and improvement of elastin, or perhaps something even deeper, this is something that evolves over time, and you can see continued improvement. Here a patient a bit younger with a little bit of eyebrow and eyelid ptosis, pre and post treatment after a couple of months, a single treatment. And here also after a single treatment, you can see some lifting of the eyebrow and eyelid. This is not a permanent response. This does require some maintenance treatment, as we've learned over time. There appears to be a sweet spot with this treatment, particularly with treatment along the jawline and the neck. You can see some redefinition. This is after 2 treatments. Again, all non-ablative, non-wounding, improvement of the angle of the jaw and some tightening of the neck. One of the things, as I mentioned earlier, people with horizontal necklines, this is something that provides a nice alternative to injections. So this is without Botox, this is without filler, this is simply with the focal point laser technology after a single treatment, non-ablative. This is now being used off the body. This is after 1 treatment at 1 month. This is a difficult problem to treat. We're beginning to expand the use of this technology to the body in different areas, including the dorsum of the hands, which I'll show in a second. But one area that I've been particularly pleased with this technology is the treatment of scars. It improves the texture of the scar, the pliability of the skin. The skin generally gets softer. This is after about 3 treatment sessions, all non-invasive without concomitant therapy. So we're using this for patients with burn scars, post-surgical scars, improves some of the erythema that one sees as well. One area that's been reproducible and becoming very important in our practice is for rejuvenation of the hand. So this is without filler. This is without any other treatment. This is just the focal point laser technology alone, and this is after 1 single treatment session. So the other thing that I think we'll be seeing more of is the concept of combination treatments. 2 examples are RF microneedling and non-ablative fractional for acne scarring. And again, the same focal point laser and pulse dye laser treatment that Rox had mentioned earlier for resistant and hypertrophic port wine stains. So this is a paper that Dave Hashemi and our group had published a couple of years ago, or even last year, looking at the treatment of acne scars, and we found that by combining these 2 technologies together at the same time, we had better results than using treatments on alternate visits. So by using these different technologies, we're actually potentiating the results of both without increasing the side effects and improved outcomes. We're particularly excited about the combination of focal point laser with the pulse dye laser for the treatment of port wine stains. Dieter Manstein had shown me casually what we call Dieter dots, these little areas of vascular injury after the use of the focal point laser technology. So we thought it might be a good idea to combine this with the pulse dye laser, and we found some very interesting results. So we're beginning to see areas of complete clearing in patients who are resistant to pulse dye laser therapy, improvement of areas that are hypertrophic in a very safe and easy fashion. We're able to do this at the same time. We looked at whether we should do this with the focal point laser first or the pulse dye laser first. It didn't seem to make a difference. It was better than either one alone. We have a paper that we've submitted for publication with over 80 patients, and the patient response has been quite dramatic with significant acceptance of the concept, and we've been quite pleased with the outcome. I want to talk a little bit about laser-assisted drug delivery. It's been mentioned a few times this morning. I think it's underutilized, but when you're talking about the future, this is the future. It should be part of the present as well. We've been using this for a variety of conditions in our practice. more and more, and it's been part of our routine day-to-day practice. If you look at a couple of papers that Jordan Wang and I had published in Dermatologic Surgery, you can see the dramatic uptake of the various different drugs. And this is all with non-ablative laser treatments. So you don't need ablation to get drug uptake. So this has significance clinically to all of us. And we've been using this a lot in our practice, particularly as it relates to hyperpigmentation, melasma, and also for rejuvenation. So Jordan Wang, in his infinite wisdom and I guess guts, volunteered his own arm for the in vivo analysis using OCT of various different devices, where we used these devices and did the OCT analysis. And you can see that there are channels after these various different treatments. The radiofrequency with microneedling we did not see at the presence of channels. Others have, so there's some debate about that. But you can see the duration of channels that we are able to visualize with this particular in vivo study. So this has real-time value in our practice. For example, when we're treating post-inflammatory hyperpigmentation or melasma, we are giving patients a topical to apply when they get home when these channels are still open. So we're using topical tranexamic acid after the treatments, and we give the patients a little solution to take home to apply when they get home, and again in the evening after they have left the office. So there are a wide variety of things that can be used. I encourage you all to read the works of Merete Herdestad from Denmark, who's doing fabulous work in this area. So this is something that Jill Weibel and David Ozog had shown, was that the application of polylactic acid following ablative resurfacing does persist in the skin. I thought this was kind of an interesting idea. I was a little concerned that there might be an inflammatory reaction afterwards, but we were able to find in not only the study that Jeff Dover's group had found that it's something that could be done clinically, but in our study, looking at it retrospectively, we found no reactions. So this is a patient with acne scarring where we used ablative fractional plus PLLA. It's applied immediately after treatment. It allows us to treat on the body as well, more conservatively. And this is the study I referred to where we had published a review of quite a few patients and did not find any problems with an inflammatory response, scarring, or nodules after this treatment. So this was 118 patients where an ablative fractional CO2 laser was used, and no issues of nodules, delayed wound healing, prolonged erythema, or abnormal scarring, so we use this routinely. Again, using this tranexamic acid topically for the treatment of melasma after a 1927 low-energy, low-density device, very, very helpful. Based the response that one saw from the patient's own investigative evaluation and the investigator's evaluation was a nice outcome. And this is something we routinely, has become standard in our office for the treatment not only of melasma, but also for post-inflammatory hyperpigmentation. A patient with angiofibromas and with tubular sclerosis, here we did an ablative treatment and used topical rapamycin or sirolimus after the treatment. A patient with extensive hypertrophic actinic keratoses, where we used cisplatin and 5-FU after a non-ablative fractional. Actually, so this was an ablative fractional treatment performed very conservatively. So just to one more comment, a couple more comments. Sometimes what's old is new again. We're seeing a resurgence in ablative resurfacing, both fractional and fully ablative. There appears to be true value that we all know about, but what's interesting is wide acceptance on social media. So this is an example of an Instagram post that I saw the other day, and these people are going online and they're promoting their own, chronicling their own experience with ablative resurfacing. I'm quite concerned about it. We are also seeing an increase in complications because these types of devices are getting in the hands of unskilled physicians or non-physicians, and so the number of problems are beginning to increase, but there is significant in this particular type of treatment. So this is something that was interesting a few years ago and widely used, but we've seen a resurgence in our practice. This is just being a proof of what one can see. So ablative fractional resurfacing still has tremendous value. We use it routinely for the treatment of facial wrinkles and laxity, but there is wounding. It does take time to heal, just some examples. And fully ablative treatments, the non-fractional, again, have significant value. So this is not going away, but I think the resurgence in interest here is of value. For example, here treating a skin flap with an erbium YAG laser, or treating xanthelasma very conservatively. These are examples of something old that's new again, where there appears to be a resurgence with significant value for the patients. Thank you very much.
Thanks, Roy. Our next speaker is Dr. Dieter Manstein. Dieter is at the CBRC at Mass General and has contributed a multiplicity of game-changing technologies, many of which with rocks. And it's always great to have Dieter come up here and talk about what's going to happen in the future and give a very exciting and unique peer into what we will be seeing in the future. Thanks for speaking, Dieter. Thanks for coming.
Yeah, thank you, Matt, for the invitation. And really, I like to talk more about the big picture, what is changing, and also I think the way we all change our thinking, basically, how we approach the problems, basically. Here are my disclosures, and there's a lot of things changing. It's really like fundamental paradigms, how we approach things. And just if you look the evolution of laser treatment indications, what we do with our tools, from the non-selective destruction to selective destruction, but now normalization, stimulation, and regeneration. So really the applications are changing. And all of you know selective photothermolysis, invented by rocks. So this is a selective destruction by matching the wavelengths of the laser with a target chromophore, matching the pulse duration with the thermal relaxation time, and you can selectively destroy like port wine stains. And for many, many years, when you heard laser surgery, it was really like selective destruction. Port wine stains, pigment lesions, hair, tattoos. So really and all of these are actually, selective photothermolysis works best when you have high contrast lesions, dark hair on light skin, red blood vessels on light skin. So that really was the main theme, and still is, of laser surgery. Normalization actually is something that became also over the years very popular. And it started, I think, with fractional photothermolysis, which we invented as a low downtime way for treatment of photoaging. That was over 20 years ago, but still up to these days, I, myself, and all of you still discovering new indications and applications. And what I mean with normalization, basically you apply a fractional laser treatment to pigmentation, to collagen remodeling, to vascularity, and you can get a reduction. You remove a pixelated matter pigment, you have a hypertrophic scar, it becomes flatter, but also very similar parameters you apply and you increase. You can basically repigment by stimulating pigmentation, the redistribution. An atrophic scar becomes increase in volume, and you can even induce some new vascularity. So you have normalization of function also, here after the morphea contracture. And even non-healing chronic ulcer can be treated with fractional laser treatment. So think about this. You have a wound, and you apply micro-wounding, and it improves. There's still a lot of things to discover. And even inflammation, granuloma annulare, quite persistent sometimes. Here, after 2 non-ablative fractional laser treatments, basically disappeared. And really, what is going on? What are we doing? Just, and I apologize, it's very small, but the point I like to make, and I don't want to steal the show, is work of my fellow who will present at the ASLMS meeting soon, basically showing that really like the dose matter. So if you have low dose fractional laser, you can actually decrease inflammatory pathways. If you have a high dose with the same laser, you increase inflammatory pathways. And same like regenerative pathways are only upregulated when you have a low dose. With high dose, you block them actually. So really like you really have to know exactly what you're doing basically. What else in the future can be done? Typically with laser we remove vessels, port wine stains. But here is an OCT image from some of our clinical work on the left side. This is a nice regular vascular treatment, a vascular network. The capillaries are very regular. It's a young non-smoker, the capillary network. But look on the right side, this is an old smoker. It's really very irregular, and no wonder that the skin is healing not so well. So the question is, can we use also laser potentially in the future to normalize it? Can we basically by microwounding restore the microvasculature? Can we restore fine nerve fiber endings which are decreased in many skin diseases as we age or in diabetic patients? So what else can we do? And I think these applications we have not really explored. We're doing some clinical studies now, but can you, nerve fibers, this is not on our radar right now, basically, to restore them, to regenerate them, and that may be a way to do so. Laser-assisted drug delivery, and there are quite a bit of opportunities. We have seen before with the presentation of Dr. Harris that there are multiple ways also to get something that typically doesn't get into the skin, but also here with fractional ablative laser treatments, you're drilling microscopic holes into the skin. So you get large molecules, antibodies. There's really no limitation of size. You can get anything in basically, like you see on the left side or on the right side, the delivery of a fluorescent doxycycline. And by changing and choosing the right laser parameters, you can decide how deep you go and the density, and you can make something like a customizable drug delivery, basically. And that's, as we learn right now, how to really use the right laser, the right density, the right parameters to really get the drug wherever we like to deliver. But you can deliver pretty much anything, antibodies, stem cell, exosomes, peptides, but please consider there are only, you should use formulations that are suitable for injections, and it's really like an emerging science for customized delivery using the laser. But there are also synergies of drugs with the laser treatment, and sometimes you do the laser treatment anyway. So you can apply then later on drugs to enhance the laser treatment. And what I don't want to forget also, and we, including myself until recently, you forget about this typically, the laser itself generates its own secretome, a lot of cytokines and exosomes. So don't forget this. People are using ablative fraction laser to deliver exosomes, but the laser itself has an excretory signature also. And this is the next theme, using the laser as a drug, basically. And I wanted to show the example of systemic metabolic effects, which in the past was not at all on my radar, basically. So when you have a laser treatment, historically, you only have literally a laser focus. You have one specific lesion. You direct the laser there and remove or change the lesion. That's a classical understanding. But we're seeing also regional effects. you treat one side with an acne laser, the other side improves. And even systemic effects, which is, I think also has to be explored much more. One example, fat removal in the past. Think about you have an unwanted localized area, you apply heating or cooling and destroy it. That's a classical thinking. But for weight loss, it doesn't work. We have done a study in the lab, that's an animal study, recently published this, to see what happens if you do a fractional laser treatment on a larger area, basically. And then you see something quite interesting. Even you treat with a fractional ablative laser only the epidermis and dermis, you have systemic effects. We can measure the body energy expenditure dramatically increases by 61%. The fat mass in this mouse study was reduced by 43%. The lean mass was not changed. And we could see also browning of the adipose tissue in remote areas. So think about this. The laser never reached the fatty tissue, but the fatty tissue changed. So further highlighting the concept, the laser as a drug having systemic effects. And not just below the area that was treated, but also in remote areas. I think this is quite remarkable, and we are looking right now if we can having these kind of treatments for example, systemic weight loss treatments. I mean, that's something in the past wouldn't even occurred to someone using the laser for this indication. It's not yet the state of the art, but this is something I predict may come up in the future. So to use the laser to change the metabolic rate and potentially as adjuvant therapy for weight management. But it's currently not recommended for clinical use. And other systemic effects. I mean, maybe we set a regenerative switch and even other organs are affected by the laser treatment of the skin. The skin is the largest organ of the body, and if that's changed, it may have effects also on other organs. Even in oncology, this is just one example, just to highlight the point also basically, and like to emphasize it's not standard of care. This is a mice study we have done with a 2-tumor model where we tested different kind of treatment modalities. And here's the survival plot, the control, pretty quick decrease of survival. When you do immunotherapy, in this case checkpoint inhibitor with, I think, OX40, we had some improvement of survival. And then when you combine this, one tumor bulk heating and surgical excision, you had some non-significant improvement. But when you did a fractional treatment on one of the tumor, and emphasize fractional, so you intentionally leave some tumor behind in one tumor, but combine it with immunotherapy, you had quite some impressive treatment response. So it's really like amazing that a partial response in combination with immunotherapy has a better effect on tumor treatment, more systemic effects than complete bulk heating. And that's also so, it's really like a paradigm change. It's actually so much that I cannot recommend it at this point. Obviously, right now, full tumor excision is the gold standard, but if you think from an immune perspective, a partial target may actually be better. But again, that's still research, and the future will show more. Will show more about this. Here's and basically you can convert a cold tumor into a hot tumor with this kind of fractional laser treatments. Robotic devices. I mean, autonomous driving is coming, but basically also just let's put it into microscopic scale, and we can use smart fractional photothermolysis devices to really detect and shoot and have autonomous robot treatments. that's coming in the future. One thing is also very exciting. With all this AI, and you can use your smartphone and detect and diagnose some lesions, but I think you still need biopsies. And I think this very simple trick right now, I can see can become also a game changer if you really use a very small scarless biopsy. And that originated from the idea of making small little microcores for skin regeneration. These are being thrown away, but we modified the cores that you see them here on the sub-millimeter, and you can really get full thickness microcores and analyze them for histology. And on the right side, you see a comparison of a 3 millimeter punch biopsy versus a sub-millimeter full thickness core. And it's very easy to be processed. You have this microcore, you can put it in formalin, and then you put it just into the processor, and you get a really nice histology, and potentially it could be done even at home because it's scarless. You can have like a spring-loaded kit, and then basically it's automatically processed, and you can do all kind of omics and obviously regular histology with this. I find it's a very interesting potential diagnostic method in combination with imaging AI. And one of my favorites is laser to treat aging. I mean, these are all the hallmarks, the root causes of aging. Don't go through all of them right now, but basically, if we can treat the root causes, then I think we really can make a difference in regeneration. And one thing I like to pick up is mitochondrial dysfunction. As you know, the mitochondria are the powerhouse of the cell. Everything is energy. And if that goes down as you age, the mitochondria, they're having their own ring DNA, no repair enzymes. So as you age, the mitochondrial function goes down. And the real eye-opening was this study from Singh, where basically he genetically engineered a mice to be able to turn on and off the mitochondria. And when he turned off the mitochondria, then the mouse basically lost the hair, got graying, got wrinkles, and got fat. So basically all what you see when people age. And the interesting thing is, the same mouse, when you turn on the mitochondria, could regain all the function basically, and could be rejuvenated by just restoring mitochondrial function. So why we don't do mitochondrial transplantation in skin? It's done in other organs already, but in the skin not yet. And could be mitochondrial transplantation really become the next big thing in dermatology? We've done some experiments. Basically, the mitochondria can be easily transplanted into fibroblasts. So to my surprise, here you see the labeling after injection. And basically, the mitochondria, after UV exposure, they're very sensitive to them. They lose their ATP production, as we have shown here. And basically, when you inject mitochondria, you can recover mitochondrial function, basically. So the ATP production is being restored, even after UV exposure. So really showing that mitochondrial transplantation can recover fibroblast function. And there are a couple of questions, of course, regarding matching of the mitochondria. Can you maybe have modified mitochondria or some off-the-shelf product you inject? It's really like, I think, a very exciting opportunity. Loss of proteostasis, basically protein falling and degeneration. It's one of the hallmarks of aging also, but think about it, heat shock proteins, they can stabilize proteins, and they're produced after cooling and heating also. So maybe we can use cooling and heating to stabilize proteins. And here it is used also, cooling to reduce skin inflammation. Here reduction of acne and even atopic dermatitis can be improved. Do I say this is a gold standard for atopic dermatitis? No, but it can really certainly make a difference. And I think cryotherapy is one, for me, of the most exciting things. In the past, it was just cryosurgery with liquid nitrogen. Then cryolipolysis, we invented selective removal of fat. But I think the cryomodulation is really interesting because it has its own secretome, it has anti-inflammatory effects. And I think like things we never considered so far. I mean, we use cooling in combination with laser treatments, but maybe you should cool before to have a secretome, to have heat shock proteins already produced, because it takes time to produce them before the treatment and not just during the treatment. So I think there's a lot of opportunities by having customized cooling treatment and changing the dose, the time point, and we are looking right now into this. And basically, we are already with many of the laser treatments. We assessing cellular senescence, we producing heat shock proteins, we know how to increase mitochondrial dysfunction, genomic instability. So many of the things we're already doing addressing these root causes of aging, and I think it's a very exciting field we are in right now, and I think some of that is already accomplished, but we have a lot of opportunities these days, and I think the next few years will really make a difference and will become very exciting. So here is a brief summary. And I think also my last slide is that these fractional lasers really cause already a renaissance in skin regeneration, but it's really like a fertile testing ground for full body rejuvenation, and there's some overlap with the longevity research. And many of the concepts we've learned in our laser field, like normalizing tissue, resetting inflammation, stimulating deep repair, removing senescent cells, improving cellular metabolism, boosting the immune system, rebuilding organs and others, will become very essential and will affect even other specialties. So the future is very exciting, and we are moving certainly from purely cosmetic treatments into medical application in regeneration and even affecting other organs. So that's how I see the future. Thank you very much.
Thanks, Dieter. The next spot. Thank you, Dieter. So we're going to move to our final presentation. It is my distinct pleasure to introduce Dr. Saranya Wiles, who is here from the Mayo Clinic. The topic is what innovations will transform the way we perform regenerative medicine and dermatology. There are 2 CME articles on regenerative medicine of the skin and hair. Saranya's led those articles, and I was speaking to Murad last night, and I'll tell you all what I said to him. I think those are going to be the foundational papers for the future of skin regeneration and longevity, and it is the journal of our society. They're both a great read. Yes. I clicked it. Oh, good, there it is. Okay, she's medical director, Center for Aesthetic Medicine and Surgery, associate professor of dermatology and regenerative medicine, Mayo Clinic, Department of Dermatology. Thanks for coming, Saranya.
Thank you all for hanging in there. The last talk of the session will make it exciting. I'm going to talk to you a little bit about regenerative medicine and where we're seeing this go. And there's a lot of speculation out there, so I'm hoping this talk will be more clarifying. These are my disclosures. So the objective of the session was to talk about innovation in the next 1 to 5 years. There's a lot of topics in the toolkit of regenerative medicine, and I wanted to distill it down from my perspective of exosomes and peptides, which really I think will help drive the immediate need within regenerative medicine. But let's level set before I dive in and talk to you a little bit about what they can do. Let's talk about what is regenerative medicine. So the idea of regenerative medicine is the idea to restore form and function. It's not just structure, it's function. With the skin, that's how do we enhance the ability for thermoregulation, for wound healing, excretion, secretion, sensation. So that's what we're looking at as functional readout of regenerative medicine. And of course, we've been fascinated by this topic for centuries since Greek mythology, and this idea that our bodies can regenerate, our heart can regenerate at 1% per year. So by the time you're 50 years old, 50% of your heart has regenerated. We know that the capacity of skin is every 30 days. And so with that in mind, we published these 2 JAD-CME articles, as Matt said, and he's co-authored on one of them. And essentially, this took us 4 years from concept to publication, and it went through multiple rounds of reviewer analysis and back and forth to try to really nail down what do we kind of think through as guidelines within regenerative medicine. This doesn't provide you specific treatment guidelines. This gives you a category to establish the lexicon. How do you talk to your peers and your patients about it so that you can be better educated, because this practice has become more pervasive. So yes, I think I got my first NIH grant faster than this publication. So I hope you guys enjoy reading this. There's really been an evolution in our field, which is that we've gone from, and really in medicine, healthcare in general has shifted from the concept of fighting disease and looking at disease as something that we have to combat to more of this concept of rebuilding health. How do we start early? How do we harness our health spans? How do we figure out this pro-longevity mindset at the molecular and cellular level that Dieter talked about earlier? And with that